Welcome back to session 2, PFA Simplified, Enhancing Efficiency and Versatility in PVI. It's another live case here from Europe, this time from Massy, France, in the Hôpital Privé, Jacques Cartier. Before I hand you over to speakers, Salem, Younsi, and Jerome Lacotte and their team, let's meet our panel. We welcome back from Chicago, Brad Knight. And we are also delighted from Athens, Greece, Dimitris Tsiachris. And fresh out of his scrub, he just came out after concomitant. We've got Dr. Julian Chun from Frankfurt. And congratulations again on a wonderful case. Let's hand this over to Salem and Jerome at the Hôpital Privé Jacques Cartier for their case.
Hi, everybody. Welcome to Paris.
Yep.
Welcome to Paris. I'm Dr. Lacotte. Salem is my friend and associate, Dr. Younsi. We're a team of 4 or 5. There are 2 reps and mappers from Medtronic because this case is dedicated to pulse select PVI and CTI ablation. So let me introduce the case briefly. There are 2 slides, but briefly, it's a 70-years-old patient. No structural heart disease, no coronary heart disease. Just 2 comorbidities. He's a smoker and his BMI is around 30. He's been under persistent AF during 3 months. We cardioverted the patients right now before the live gets started. So it's the first episode of 3 months persistent AF converted to atrial typical flutter under immunodaron. That's the reason why we're going to ablate both sides. In terms of settings, the patient is under GA. Of course, he's paralyzed. We have no 3D mapping, no eyes. France is a very poor market. It's only 6,000 euros for the DRG, including the device, and there is no bonus for mapping 3D or for eyes. So help will come from CT Fusion. We have AW solution from General Electrics. We're going to show you our experience. We have performed 500 cases like that over the 12 last months, including 16% of patients with CTI. We'll show you after PVI the 2 options, the 2 strategies to ablate CTI in a safe and fast manner. So transeptal is ready. ACT is above 350. Everything is okay, Salem?
Everything is okay. Hi, everyone. Ready to go. So we'll start. We have our catheter in the left atrium. This is a horseshoe-shaped catheter, and it's guided over the wire. So we have the guide wire in the superior pulmonary vein, and the first thing is to have contact. As you can see, the 5th electrode, that is the summit of the horseshoe, has to be in contact with the pulmonary vein. So I will advance it and
let me rotate LAO and show to our colleagues that we are really inserted inside there on the left upper vein.
Yeah.
So do you like AP projection or LAO, Salem?
I think, we have to navigate between LAO, AP, and RIO because to determine where is our situation going ostially and antrally, we have to navigate. I know that in the US, for example, they are using very often ICE and 3D mapping. So in France, we try to keep it simple as we were doing when we were doing cryoballoon ablation. And yes, that's the strategy we are using, really old-fashioned EP and fluoro only.
Just one comment about access. In terms of simplification, our daily workflow is just 1 puncture for the dedicated sheath. It's a steerable Medtronic sheath. we did the transeptal with it. We do not exchange other wire. It's only one growing puncture, one transeptal puncture. It goes very fast this way. And in this patient, there is a second puncture and a pacing catheter inside the CS because of a flutter. In other patient, there is no other pacing catheter. Maybe will be a discussion on that, but we decided to put to insert only the ablation catheter.
Yeah, because we are doing very often ablation in same-day discharge patients. So one growing access means, I think, less complications. So
Yeah, you're right.
that's it. Okay, let's do some ablation if everybody's
So-
okay.
Tell us if there are questions regarding the technology, the design of a catheter, the workflow. Just to remind you that
Initial
Pulse Select,
thoughts from our panel
Yep.
on the setup?
We talked in
Dimitris,
There's no
maybe we
question?
can start with the setup, so his comments.
okay. Allez, let's start PF. First position. Salem, you can start, and I will remind you how it's recommended to disconnect veins. So there are 4 positions. One can see that the horseshoe is facing the south, or the bottom of its vein. And Salem, so first, 1, 2, 3 pulses, 1,500 volts. It's 10, no more signals. And Salem is now rotating with his right and 90 degrees. And now the hole faces the anterior part of the vein. So next pulse, it's recommended to deliver 4 pulses on the the 4 cardinal points of the ostium. And it's uncommon that we add more pulses compared with antral position, where our experience, our feeling is that we should add more PF. So it's your 4th application, Salem? Third?
This is the south one.
In terms of
6 o'clock.
in terms of contact, you know that there is no yet any technology predicting or determining the contact and the lesion. So it's tips and tricks. You push. When it tilts, you have a good contact. That's for the osteal applications. We will later tell us how to look for contact during the antral applications. So that makes 4 applications for this upper vein.
So we have a little trick to show you with the fusion. We can put a little marker in here telling us that this is the ostial position. So we can go around this to perform the antral lesions.
So once the ostial shows normal potential, we pull back until we find new other potentials. It's let's say 1 centimeter. Look at the signals. There is far field of LA, near field. So this is ostial. This is ostial or antral?
This is, I think it's antral because I moved a
Antral.
little bit.
So
Mark?
a few comments about antral position. Wait a second. Antral position needs
Dimitris,
that
can you take us through? Dimitris, can you take us through again, like how many lesions you typically will use per, and what your rotation strategy is to get ideal coverage, and antral versus osteal?
Yeah. So for osteal, it's 4 position overlapping with counterclockwise rotation. It's done for this upper vein only. And then you move back to the antrum, and antrum requires that you use the sheath clockwise to go posterior, counterclockwise to go anterior. that you steer and unsteer the sheath to go up and down. So that makes 4 positions recommended, like the 4 poles. In our practice, after 1 year, we think that it's better to add lesions like another cross, northwest, northeast, in between these 4 cardinal poles, except for specific patients like left common trunk. So it means that knowing where is the horseshoe, for example, if the horseshoe looks the bottom of the LA, you must not burn the upper part of the antrum because the horseshoe is up. So when the horseshoe is up, you can ablate the bottom of a carina in this patient. You can rotate clockwise to ablate the posterior part of the antrum and rotate counterclockwise to reach the anterior part of the antrum. And then, using the rotation of the sheath, move up to find at least 1, 2, 3, 4 more positions. It's very important to look that you can make a loop using the sheath around the antrum and that you won't find any more potentials in this antrum. In the beginning, after disconnecting the right veins, we were checking the left veins again. It's a sort of reflex we have from RF years, cryo years. But if you find potentials 20 minutes after Salem did that, it means that you left a gap. It's not recovery. It means that you left a gap. So it makes no sense. There is no waiting period, in my opinion, in our experience. You must take care that you ablated everything around this antrum. So the major concern is where is the antrum? To identify something like a vertical line, it could be the spine or here with a fusion, knowing that after or on the right of this vertical line, you mustn't find any more potentials. So, for example, Salem uses the horseshoe open on the top and is rotating the sheath to go down, down, down. Look at the shape of the wire. The shape of a wire like NAND plates. It's looking down on pulse. Let's ablate that. So you cannot rely on signals.
Tsiachris?
You've ablated. Yeah, it's via
Dr.
cross.
Tsiachris, can we get some variations on this approach in your own practice?
What we do in every case is that as you have now the view of the CT, that helps a lot in a patient with GA. Mostly we perform these cases in a deep sedation setting under propofol. So that kind of image will not be very helpful in these centers. And we prefer to have a venography of each vein before it's through the flex cath sheath. And this is what we use in order to orient and facilitate the maneuvers in the vein. Of course, we have another protocol, which is going to be presented in, I think, 1 month as a late-breaking clinical trial, that we have performed a lot of pulmonary vein ablation using this catheter with inside the veins, and we have already proved that in a durability study with venographies in all veins 3 months later, that we had no reconnections, 4% only, and we had no stenosis in any of the veins using this catheter deep inside the pulmonary veins. On the other hand, the approach of 4 lesions, as you said, in the way that it is used exactly the way that we use it. After PVA, we start with always with ostial lesions, without using the sheath. And for the adult lesions, we need the sheath for the anterior and posterior positions with the clockwise and counterclockwise maneuvers. And of course, we also use, we use more lesions in each vein, at least 6 per ostium and 6 per antrum in every case.
Yes. So we, our first cases to get used to this catheter, we were using some cases with 3D and, like you said, with angio to really get an idea of the anatomy, and doing now 500 cases, like Jerome said. Now we are confident and used to get some the treatment ticks to say that the anatomy is well known, and we can navigate pretty easily in this atrium. So we are now in the inferior pulmonary vein.
We move to the upper vein, and Salem will fire four times for the ostial position. So he's moving forward.
Okay, I have contact.
It tilts. He gets signals. Let's go. Let's fire. I would like Mary to show you our rep, Medtronic rep, to show you something important to understand the antral applications. Rudy, would you please focus on the white, on the generator? Yes. If you close, let's close. Yeah. Just to show you, if you face the camera with a loop, but when you rotate your shoe, the shaft is not in the middle of our shoe. It's closed from the horseshoe, the gap. So when you rotate inside the sheath, knowing that pulse select is larger than 2 centimeters, it means that you rotate around the shaft, and it covers a larger area than rotating inside the vein around the shaft. So this could be a position application for anterior antral. If you rotate horseshoe up, you go down, horseshoe down, horseshoe up, and you bend the sheath. See, it's difficult. I'm sure you understood. So how many applications, Salem?
This is the fourth one.
Fourth one.
The ostial fourth. I'm trying to get some contact in here.
Looks for contact. So I remind everybody, I remind all of our colleagues that you cannot select electrodes yet. There will be an upgrade of generator, leaving you free to ablate nice sort of double potentials between far field and near field.
Yeah, this will be very helpful, I think, to ablate the CTI. We'll discuss that.
Yes, for the
later.
CTI.
And to do some, let's say, focal lesions. And the other, like, improvement of the system we are hoping to get very soon is the 3D integration, I think,
yes.
And with some, let's say, some technology reflecting and giving information about contact. I think those two tools will be very helpful.
There are discussions every day between us. We are a team of 9 senior electrophysiologists associates. What do you want to use next year? Afera, Pulse Select, other technologies. And there is only always discussions. Do we need 3D mapping for this patient? Is it saving time? Is it losing time? Is it safety? In terms of safety, after 500 cases, we have no major complications, 0 complications after all these cases. I mean, no stroke, no pericardial effusion, no symptomatic phrenic nerve pulses. It's one another question. Do we check phrenic nerve capture? No, we don't. And fistula, of course. So no major complications. a few patients with hematoma, growing hematoma, but a limited number of patients compared with other technologies, especially cryo with bigger sheath. A majority of our patients are ablated with same-day discharge, more than 60%. So regarding safety, honestly, we don't know, Salem, if 3D mapping will help. Regarding efficacy, the survey, the registry we've done after 1 year, no, not 1 year, 6 months follow-up is 12% of reduce. 12% of reduce after pulse select ablation, including our learning curve in the beginning, and including 40% of persistent patients. And for this persistent AF patient, we only perform PVI in some other CTI line, but no PVI plus. We never perform PVI plus, knowing that there is no evidence that in first line intention it works better. Not knowing what to include in PVI. Posterior wall, appendage, you cannot do that, honestly, I think. So our workflow is very basic. It's 7-8 patients a day. PVI and cardioversion is if needed. And we are quite happy with that.
So this is our 6th application around the antrum of the inferior left pulmonary vein. And I think we'll go and ablate the right pulmonary veins.
Let's move right.
Can you
So I
give us
pull
a
back
sense
the-
of how much skeletal muscle stimulation there is during these applications
Almost known.
with a propofol strategy?
Almost no. Our patient is paralyzed. We have no experience using
General anesthesia.
other anesthesies.
I see.
Ok, tu peux voir le caté? Un peu
Rod, if
monter?
I could make a comment
If I'm
about the use
allowed.
of 3D mapping.
Reste dans l'œuf.
Ouais, monter, lever, un peu. ouais.
When
Reste dans
we
l'œuf.
use pulse select, we
Non,
use
non, non,
3D
c'est pour
mapping
mieux
and
bien
ice in
être-
addition to fluoro, but the comments were very good about relying on the electrograms, but it's made me think about how some systems maybe are more suited to using the electrograms to target the next site. So for example, when you use an Affera catheter and you go to a place adjacent to where your last lesion was and where the mapping system would suggest you need to give another lesion based on those algorithms, there's often no electrogram there anymore. So it may be that the use of electrograms is very dependent on which system you're using. The pentaspline catheter often gives you far field signals, particularly if you're up at the roof and you may not need to give more lesions. So different systems may be more suited to not using a mapping system.
Great comments.
Yes,
Jerome.
the only endpoint we can compare is redo rates, failure rates. So we move.
Regarding the mapping system, very soon we will publish our study comparing pulse select ablation based on mapping versus conventional ablation, where we proved that there was no difference in efficacy and in durability after 3 months. Of course, in safety too. According to your experience too, we totally agree. And regarding the persistence of the electrogram, we can say that the pulse select catheter leaves a less stunning effect in the veins and the potentials. You can see that when you rotate the catheter, there are still potentials in the in the anterior part when you ablate in the posterior part. The whole vein is not, it's not a one-shot technique. It's a segmental ablation in its lesion. In a way that it's true that you can see potentials every time you rotate the catheter in a new position.
And in this study,
Yeah, also if I
mentioned,
may comment,
What
And
about PV reconnection?
maybe
You have any idea of how many veins reconnected in your comparison between mapping and no mapping?
It was 3 versus 6%. Mapping was worse, but not statistically significant.
So in our registry, it's
We have
40%
some comments.
of few patients
We have
with
some comments from
reconnected
Dr.
veins.
Julian Chan.
maybe I would like
Please,
also to
yeah, Julian Chan.
ask. Yeah, thank you very much. Beautiful case and very elegantly how you move, and also a very
Thank you,
pragmatic
Julian.
European style procedure. I would wanted to maybe discuss the also important question, I believe, of the level of isolation. And as we have seen here, a couple of rotations are needed, and the device itself, I think it comes in 25 millimeter. So therefore, as we also discussed before, it's in part, if you want, a segmental approach. And do we all agree that a very, very antral must be superior to let's say an ostial isolation, or is it too much, or is a more permanent, durable isolation maybe outweighs the potential benefits? I'm just bringing up this point of discussion.
Yeah, you're right. Based on RF experience, it seems better to ablate a large part of the antrum. All the patients we remapped for redo cases were having large scars, honestly. And to be honest, a few patients in the beginning, we left one vein. One vein was not ablated, hard to find, or maybe we were confused with the anatomy between upper branch of a lower branch of the upper. I don't know, but it seems not that difficult with 10 burns per vein to have nice lesions, wide and durable lesions. But it's the early experience. There is a lot of things to understand and to discover. But it's honestly a mental stress. It's you have to be concentrated, focused on your fingers, on the X-rays. Try to understand where is the horseshoe, where is this application, the previous one, to make it continuous. In our registry, using the CT fusion reduces by 30-40% X-ray duration. X-ray duration right now it's 13 minutes. But we spend a lot of time preparing the case before the live. So it's not comparable with everyday ablation. We are around 10 minutes using CT, and plus 3 minutes when CTI is performed. You will see that, so the lower right vein, you'll see that CTI requires two different or specific approaches, and requires X-rays, of course, with 2 different projections. So Salem, you're rotating, it's a second pulse, ostial position. All the first electrodes shows no signal. They are disconnected by the PF you did in the upper vein, Salem. Is there anybody in the audience checking the phrenic nerve during these PF procedures?
It's a good question.
Not with
I think there's I may start. I think there's, of course, the issue of some transient affection of the phrenic nerve function. And to the best of my knowledge, I have seen a case report also reporting at least some phrenic nerve injury using this technology. I think overall with PFA, a transient dysfunction can be observed with any technology. and the overall risk, at least in
Yep.
what I know from literature and personal experience, is very, very, very low. Zero. I don't know if you have zero in medicine.
So the average burn, the average application is around 10 per vein now in our center. It's 4+4 recommended by Medtronic, but we are close from 4+6, 6-7, except for left common trunks. Honestly, left common trunks are quite fun to ablate, as you can merge the 4 pulses of each antral vein. It's only one, so it goes faster, of course. I prefer to have a left common trunk than 2 early branched veins or 3 veins or a large carina. So Salem is rotating clockwise, the sheath and the catheter to burn the anterior part of the right antrum. You're rotating the sheath counterclockwise.
Yeah.
And the horseshoe is looking at the bottom.
To get the carina and the intervein.
Yeah, you ablate the carina.
Yeah. And I really like this
Right.
horseshoe shape that can go more wide, like elliptical. And I think with this shape, you can go more wider.
Wider. So there is a far field of right atrium because we're still pacing the CS. It's useless for signals. It's just to have a stable rhythm. The faster you pace, the faster the generator delivers 4 pulses. We never use nitrates. We never use atropine in every patient.
So some extra lesions in the carina whenever I see a suspect signal, even if they are really narrowed.
So tell us for the colleagues watching the live and using Pulse Select, do you check the veins? Do you go back to the left veins to check potentials before leaving LA?
After the durability study, not anymore.
Yes, we do. I think with regard to the use of a mapping system, if you're not using it, I would look at the posterior wall with the device and make sure that you have a reasonable electrogram still on the posterior wall, that you haven't created a very narrow delayed isthmus in the posterior wall. That's where I think there's some value
Yeah.
to the mapping system, is avoiding making the lesions too antral in the back of the left atrium.
Very good remark.
I'm going to ask Damien, supporting the fusion, if the system is able to tell us the distance between the 2 green markers, even if it's not perfectly accurate. Damien, tu peux nous dire combien il y a de distance entre les verres de gauche et les verres de droite? How
Yeah.
long? Huh? Damien says there is 55 millimeters between the top of his 2 encirclement. Oh, so okay, we're back inside the left upper vein. Interesting signals if you we burn again.
Yeah,
We blade
I
again.
think there are
Okay.
double
That
potentials,
maneuver-
and maybe the second one is I think is Venus, and the other one is
Yes,
far field, I think, from the
far field, near
left upper
field,
page.
or incomplete block, entrance block. No one knows. Look at what happens after pulse.
Yeah, the second one I
One way
think
to-
disappeared.
yeah.
So
The second disappeared, and the first is very small. Let's rotate. Do you want me to give you a different support with PV tracker?
Yeah, that's right.
Check, check, check.
Just going back to the
Can you?
horseshoe shape.
Yes,
that
I
I
would like
so
to
much.
go up, up, up for different,
Okay.
to make it stable with different.
I think we did a good job. I think those are far field signals. What about going in the inferior
Okay.
vein?
So how long is dwell time, my friends? Someone knows how long we spent on the left side?
The inferior vein is also isolated.
No? Yes, it's 30 minutes left. The average is 25. It's not a competition, but the interesting thing is not how fast it goes, but how predictable is it? It's very uncommon to spend more than 35, 40 minutes. So for the CTI line now, you want me to do it? So yes, there are two ways to do that. The circular, you can use a pulse select catheter with its nominal circular shape as you do PVs. It means that when you insert through the IVC, let's say it's LAO projection, you will get the horseshoe in the back. And if you apply with the sheath, if you bend the sheath on the CTI, as you cannot select electrodes, you will get two lines, which is not ideal. And you have to rotate lateral to prevent any septal damage, of course. In case of long CTI, you will miss the ventricular pole of the CTI. So some of us are using this approach, which is much more simple and which certainly will be much more simple if you can select electrodes. But we are still preferring the linear approach. So look at what Salem is doing. This is RIO projection, and the PV tracker is pushed to the RV apex to provide a nice stability in terms of rotation, mainly. Salem is now pushing out the four first electrodes. Let's say 4 electrodes will mimic or corresponds with 8 or 10 millimeter tip RF electrodes. PF will be delivered between 1, 2, 3, 4. So if you push out only 3, it makes ablation, it delivers PF only between 1 and 2. So the balance we've decided to choose is to push out 4 electrodes. So we have now something like 15 or 20 millimeter RF catheter. Salem rotated left. He rotated left. The sheath is bent and adjusted to give a good contact on the CTI. And the third step, first 4 electrodes out, the wire at the RV apex, and the last step is to rotate the right end in order to get the electrodes behind the shaft and the PV tracker, because generally when you adjust things, electrodes are above the sheath. So you rotate your right hand to put them close to the CTI.
I'm just trying to get some ventricular signal in here.
Yeah, we have no V signal. If you rotate counterclockwise, do you find something interesting?
Not really for now. Oops. Yeah, I try to have more ventricular signal. Not yet. I will just recheck in the RIO, see if I'm really.
Yes, Salem is rotating RIO again.
Yeah. It's really going into RV, so there's no doubt about that.
And you think the guide wire
You want
Okay,
to-
I have.
the RV or in the step?
Yep.
Yeah, it is.
Yep.
So we have
Ectopy,
ventricular
yeah.
signal in here.
Yes, ectopies.
Ventricular ectopy. So this is, let's say, a little bit septal to ablate here. So we are going to try to go.
So projection is 40 degrees LAO. So let's add some rotation, but we are losing V.
Yeah.
Let me
Yeah,
move.
maybe just a little help with the catheter.
Ouais.
Yeah, the guide wire seemed very septal for the RV.
Yes, you're right.
Yeah.
It's
Let's
trapped.
try
It's
another
trapped.
approach.
Okay, rotate counterclockwise. Salem. In some patients, we inserted the wire in the RVOT to have a better contact. Okay, try to go out.
There.
Yeah, let's go. RIO, we see.
RVOT provides a nice contact, but it's
Yeah, now
no,
we are.
no.
Yeah.
Not too much. Okay, 4 electrodes out.
Let's go.
LAO.
RIO.
Do you have 4 electrodes out, Salem?
Let's go.
Okay.
And go. Rotation.
If you rotate counterclockwise,
Yeah, I think the catheter is going all septal instead of going to the apex. That's
Yeah.
why we have this difficulty to achieve. Yeah, maybe like that.
just like that. Okay, push out electrodes. 1, 2, 3, 4.
Yeah, it always goes septal, so it's the difficulty.
Okay, and if you
Nice.
pull back the sheath, it's not better.
No. What about here? No.
RV apex, RVOT. Attends.
Okay, let's go. As you can see,
Let me move wire.
rotating the.
Mm,
Let's try another approach.
Attends. Less curve. Less sheath.
There. Yeah.
Attends. Just wait. Thanks. Okay,
Okay.
remove the sheath. Remove the wire.
Okay.
Okay. Pull back.
Okay, that's nice.
Okay. VT. Remove the wire.
It's removed.
Okay. AF. AF. Attack. Okay,
No,
let's
it's
bend
okay.
that. Okay, I pull back the sheath to have better contact. I know there is a small V potential, 1, 2, 3, 4 out. Okay, let's go here. We have A and V. Let's burn.
Okay, let's pull back a little.
Ouais, on pull back like a basic RF catheter back. Let's burn. So it's not the best. It's not the best picture we can show you. It's very subtle. It's not. It's real life. Allez, vas-y,
That
tiens.
looks like
Yes, we have a block. Not far. The Venus pole is still connected.
sometimes it's nice.
There. Yeah.
Okay, burn that. It's a long isthmus, or it's we are not parallel with the isthmus. That's why it's so
see.
long.
Can you measure delay, please? Yeah, 140.
Burn that again, please. 4 electrodes out.
Nice.
Nice double potentials. So honestly, we're not proud to do that. It's not done for that. It's not forbidden to do that. It's not that difficult. And knowing that we have 16% of patients requiring CTI ablation during PVI session, it seems to me a big advantage to be able to do both without switching generators, catheters, technologies, troubleshooting, especially for patients. Sometimes switching AF to flutter during the ablation. And we do hope that the other technology, let's go for a few other minutes of X-rays. It's too late to show you the signals in this case, but we have above 100% of acute success and only 2 redos among 60, 70 patients. So if we were using the pulse select with this nominal shape, the circular one, I don't know where we are on the septal side of the lesion. Yeah, I think it's not that easy for long isthmuses or irregular, pushy isthmuses. So let's check the. It's generally just a few PF applications, 3-4 in average. And nothing else to mention. Can we check the surface ECG? We never had any STEMI doing that.
There's an issue with your mic, so not this one. It's not this one.
While they're proving block, can we get some opinions from the panel about CTI ablation? Number 1, empirically with PVI. Number 2, if you need to do it with PFA versus RF. Maybe we'll start with Julian Chan, and then we'll go to Brad Knight, and then Dr. Tsiachris.
Yeah, thank you, Rod. I think there's maybe some arguments why you can do it empirically. However, on the other hand, we know if you go for a good PVI, there's smaller randomized trials which also could show that CTI flutter, even despite of having the CTI flutter, may not occur over time. So I would at least in our situation or in our institution, an empiric CTI is not performed. Of course, you do CTI if it's a patient of clinical CTI flutter. And knowing that the RCA, knowing, of course, there are sort of complex ideas how to use nitro and maybe also pressors in order to avoid spasms. So pushing the gas, but also taking the brake, both of them at the same time, I would rather go for RF in a standard case.
Brad Knight?
Well, I've used several of the PFA catheters to ablate the CTI. Some are better suited for doing that than others. In the pulse select catheter, I've tended to put all of the electrodes out. I know that there is this strategy of being selective and using just the distal 4 electrodes. They're all very effective acutely. I think the question is how durable they are. When you put the 4 electrodes out with the pulse select and deliver energy through all of them, I'm just not sure what's happening inside that sheath. I mean, they're insulated, they're not touching tissue, but is the current flowing?
Can we show
Tsiachris, some thoughts before we get back?
Eager to use PFA on the CTI.
If I'm allowed, we have described our practice in CTI with pulse select 1.5 years ago. We have a very large series of very good results. We use the catheter as it is used in the veins, in the circular way, with the horseshoe up, and we point the central iliator 5 towards the isthmus. We start applications from the ventricular part to the superior vena cava, to the inferior vena cava. We started to do the first cases using mapping in order to facilitate this procedure. Now we use it only without mapping and without even any use of nitro anymore, with very good results in a very, very fast way. We did only 4 to 5 applications.
Well, I think that obviously the operators here have done a wonderful job to be able to take a catheter that's not designed for it and be able to exercise, their skill set to be able to do it. But I personally have abandoned CTI with PFA for the reasons I've all mentioned of spasm. And I think with durability, and I would love to see some longer term durability, but we just saw Natali's group led by LaFazia et al. Showing that the durability for mitral lines was only 6% durability of CS with large footprint PFA. Every PFA system is different. That is true. But when we think about durability, acute block may not even indicate something durable. But again, the proof is in the pudding with clinical outcomes. If this group has only seen 2 recurrences out of 70, the question is that acceptable? And that obviously sounds pretty good. But even Greg Feld, the OG of CTI, has abandoned routine CTI ablation with PVI if there's no flutter. And as we all know, Wozny and Natali hypothesized that CTI in addition to PVI would work, and actually in Circulation they published in the early 2000s that there's no benefit doing it. So I think this is still the holy grail of figuring out which patients need it. Because the biggest mechanistic question is, everyone has a CTI, how come not everyone gets CTI flutter? And as Julian very well articulated, if you do PVI for patients with CTI, there are data, even randomized, to show that they don't have CTI flutter again. So it's a very interesting thought exercise with whom we should be doing it. But this is really nice. Can we go back to Paris and ask them about their acute outcome? It did appear that you had prolongation of the transismus time.
Yes, everybody, we were still a nice catheters out, and we were having 170, 180 milliseconds of delay. I share all your comments. We need versatile catheters to be able to ablate veins and, if possible, lines, specifically flutter lines for patient needing it. And I do share the other comments that I'm afraid we will have to, or I'm happy that we will have to rewrite every paper published or every study done for 25 years now. Now with RF using PF, every PF catheter is different, provides different lesions, and all this needs to be investigated and published and shared.
Well, I believe we have about 1 minute left. So if you can give us a full wrap up, and I want to preemptively congratulate your team in Paris for a really beautiful executed
Thank you
case
very much.
and the opportunity to discuss this. And
Marie, tu viens?
It was really
What
a
about,
pleasure.
just one last question. What about CT fusion? What is your feeling about that from this case?
Very nice.
Dr. Tsiachris, CT fusion.
It helped a lot. It seemed to be very nice.
Can you repeat that again?
Yes, it seemed that it helped a lot. I liked it a lot. It was very nice.
Julian Chun, obviously in the US we use ICE, so we probably don't use CT fusion as much. Your use of CT fusion at CCB?
No, we don't use it on a regular base. But it was nice to see, but still we should not forget it adds a complexity in the planning, and it also adds fluoroscopy or exposure.
Well, thank you very much from the Hospital Privé Jacques Cartier. A beautifully executed case. Congratulations, and thank you for taking us so nicely through session 2. Hats off to your team.
Very nicely done, yeah.